Hello, future PTAs. Hope you guys are doing well. Today we are going to talk about issues concerning the elbow and forearm, and then we will switch lectures and go to the wrist and hand. So starting with the elbow and forearm. First we'll do palpation. So we'll do this in the lab, but I'll just kind of go over our lateral epicondyle on the outside of the arm, the radial head. Remember, rad is on the thumb side, so the radial head is on the thumb side. The head is at the top. The medial epicondyle is on the inside. Cubital tunnel is right there. If you hit your elbow and you have those shocks coming through, that's the cubital tunnel there, and the ulnar nerve passes through the cubital tunnel. And then your olecranon is the big bone there of your elbow, your fat pad behind it, and then the olecranon fossa. So we'll go through some palpation in lab. Referred pain, typically at the elbow, it's more pain that goes all the way down the arm. So the heart pain can go all the way down the arm, especially on the left side. Your neck pain can come all the way down the arm. With heart pain, it's typically more on the inside medial aspect of the arm versus from neck pain, it's typically more on the lateral aspect of the arm. So that's one way that you can tell with that. The neck pain that I'm referring to is typically coming from a pinched nerve or a nerve root that exits from anywhere between C5 or C7. If they have T4 pain, so if the nerve root exiting at T4 is getting compressed, then that may refer directly to the elbow. And then shoulder ailments can refer pain to the elbow or down the arm in general, just depending. And then as you see on this side, the rotator cuff will refer pain that typically stops at the elbow. And then the forearm muscles are typically in the forearm, so not usually affecting directly at the elbow, but that pain will start at the elbow. So the nerve injuries that we have from elbow concerns, cubital tunnel syndrome. So most of us are familiar with carpal tunnel, but cubital tunnel is where the ulnar nerve is getting entrapped, where it travels through that cubital tunnel. And the pain pattern is this red portion as follows, the pattern of the ulnar nerve. With the radial nerve, so if you'll look on the colorful arm over here, the radial nerve is the red, so kind of the back portion of the arm and into the dorsal side of the hand, especially the more lateral aspects, versus the median nerve is on the median side, so it's the purple on the colorful arm. It's the purple. The median side of the arm and down stops about the wrist, so if there's any median nerve entrapment. Now all three of the nerves kind of come underneath the arm and travel down the arm. The radial nerve, I think I have a picture of this somewhere, but the radial nerve then kind of crosses, so ulnar, median, radial, crosses. Let me see if I have a picture of that. I'm not seeing it right now, but right, yes. Okay, so the ulnar goes behind and travels through that cubital tunnel. Then the median is more in the front, the middle of the arm. The radial is the one that crosses in the front and goes kind of on the more lateral aspect of the arm. So the median goes on the ulnar goes on the most medial portion, and it's goes through the cubital tunnel. The median goes down the middle, and then the radial, although they all come kind of under the arm, goes and crosses over more on the back side of the arm, the more lateral aspect. All right, so now we're getting into issues that can occur at the elbow and how we treat those. So when someone has joint hypomobility and there's no specific diagnosis, that just means limited movement at the elbow. So the treatment, you can do soft tissue or deep tissue mobilization, so massage type techniques. Joint mobilization, Now, one of the main things that we'll do is joint tracking. So in the picture you see he has like a belt or some type of mobilizing belt that he has hooked probably around his shoulder and neck up here, and then he is using it to pull the bones laterally while he passively flexes and extends at the elbow. So it's doing a lateral glide. The belt is what's doing the lateral glide while he passively pulls them into elbow flexion and extension. That can help with your elbow joint tracking. And then with hypomobility, eventually, once you get the mobility back, you can do some strengthening in order to kind of stabilize the area, and then some stretching. Of course, with any type of decreased mobility, we want to stretch the area out to increase that mobility. Modalities would be at targeting the hypomobility, so you could use ultrasound to help loosen up the area, promote healing, get any inflammation out of the area depending on what modalities you're using, ice or iontophoresis, anything that you need to use for inflammation. So the modalities here for the elbow are typically ultrasound, ice massage. You could use heat or regular ice, and iontophoresis is used at the elbow. You may be able to use laser diathermy for certain conditions. Okay, one of the ailments that can occur at the elbow is a proximal radial head dislocation. So this most often happens in children, especially those under 5. And we call that nursemaid's elbow because as you see in the picture, it's usually somebody is holding the child's hand and holding it up and kind of pulling it up, especially if you're walking through a parking lot or something. They're kind of dragging the kid along. The kid's saying, I don't want to go. They're dragging them along by their arm, pulling on that elbow. And the ligaments there are not typically very mature before age 5, and so it's easy to dislocate that area. And so what the proximal radial head is dislocated, so it comes out of place, and then that in itself limits the elbow movements. It limits wrist flexion and pronation as well. So in the picture you see the little girl, it's came out and now it's sticking posteriorly. What we would do to relocate it, which would be the first thing, you wouldn't want to just avoid it and do therapy. You need to relocate it. They may be able to relocate it by themselves by just flexing and supinating. So supinate the arm and then flex it, and it may go back in by the distraction force that's occurring there just with that movement. If not, then you can grab the proximal radial head and do a distraction force, and then it can relocate there. You could even have them flex after you pull it into distraction. Once it's relocated, you certainly want to stretch any muscles that are tight. Most likely, immediately, there's going to be inflammation and soreness, so I would focus on that the first treatment or two, and then down the road give more stretching and then strengthening to prevent that from happening again. With Olecranon Bursitis, remember the bursa is like a fluid sac that is over top of a bony prominence just to provide some type of a cushion. So there is a fluid sac over top of the olecranon because there's not a lot of tissue on top of it, which is another reason it hurts when you hit your elbow. And Olecranon bursitis is just the inflammation of that fluid sac. So the main treatment would be focusing on decreasing the inflammation. So you could do anti-inflammatories, which would be prescribed by the medical doctor, not by us. You can use splints, braces. Offloading braces are the type that we typically use. Some of the ones for this condition will have a pad there to keep anything from bumping and causing more pain on that area. It's a very painful condition. RICE, so rest, ice compression, elevation. We certainly want to offload that area as much as possible and not stir up any more inflammation. And then targeting the muscle imbalances, or the triggers. What caused this? Were you playing this sport the wrong way or too often? Were you doing this with poor mechanics? So figuring out the causes, figuring out, what is leading to extra pressure and inflammation in that area, and targeting the muscle imbalance or the causes, poor mechanics or whatever they're doing there. You might need to do an ergonomics assessment. How are you sitting? What is your desk like? Are you sitting with your hand like this all the time, about half falling asleep in the middle of a lecture? And trying to avoid whichever positions are causing that. And then stretching the area. Of course, you're going to stretch the forearm primarily, and then eventually going back to strengthening whatever muscles are weak. That is with Olecranon Bursitis. I showed an ice massage here. I love ice massages on hands, elbows, really bony areas, because sometimes it's hard to get the ice to form around it, and sometimes it's hard to get ice specific to exactly where we want. So what we'll often do is freeze like a Dixie cup, fill it about halfway with water, freeze it, and then peel the top portion off. You might have seen that in the clinic. Typically with an ice massage, it takes around 5 minutes before they get numb. May take a little bit less or a little more depending on how large of an area you're doing. And it is very effective. A lot of patients really like it. All right, Myositis Ossificans. That is the formation of bone in an atypical location. So sometimes that will happen in the elbow, especially after repeated trauma or impact to that area. So this is the extra bone that's forming here. It may require surgery. There's nothing we can do to remove it that's not surgical. But, we could, if they're wanting to avoid surgery, still treat the patient with stretching and modalities and things just to comfort them and help decrease any flare-ups. But in order to actually get rid of the bone development, you would have to have a surgery. So you have to find a balance between stretching the area and avoiding tension on the area. So stretching in itself, although you're trying to lengthen the muscle so that there's less tension on the area, the stretch itself puts tension on the area. So you kind of have to find a really gentle stretching type technique that can help lengthen the muscle so that there's not as much tension on there all the time, but also doesn't overstress the area while you're stretching it. So vigorous stretching is not recommended in the least bit, because that puts extra tension on the area, and sometimes the tension itself can cause extra bone growth, like with Myositis Ossificans, or for a child in the knee, it would be called Osgood-Schlatter. So if surgery is performed, then after the surgery, they'll use a Cpm machine. Remember, that stands for continuous passive movement or motion, continuous passive motion. And you would strap the person's arm in and set it to a specific degree of movement and specific speed of movement and how long you want it to last. And it will just take the patient's arm slowly through that movement over and over until the time period is ended, if you sit it for 2 hours or however long. And so that way it's providing that gentle, light, stretching, fluid movement to keep more bone formation from forming, or scar tissue or any of that, without putting stress on the area. So that would be recommended after surgery. And then also a hinge brace. So one right here, like you see them oftentimes in a knee patient, a hinge brace where you can lock it to where you cannot overextend or overflex. Same type of technique, same type of device that can be locked so that you don't overextend or overflex, depending on what the surgeon recommends the degree of movement be. With tennis elbow, that used to be called lateral elbow tendinopathy. We call it now. It used to be called lateral epicondylitis. Most people I've worked with still call it that. But now the new name for it is lateral elbow tendinopathy. Remember, we talked about tendinopathies with the shoulder, and with a tendinopathy, occurs with chronic stress and inflammation to the area, and eventually the tendon begins to kind of break down. It begins to become more weak. So tennis elbow is actually a weakening of the tendon in the lateral elbow. So right where it attaches to the epicondyle, that would be why it was called lateral epicondylitis, inflammation of the condyle, but the more accurate term is really lateral elbow tendinopathy, because the tendon itself is beginning to kind of tear down. And so we want to prevent that from happening in the first place. So it would be better to get it when it's just kind of a repetitive inflammation, kind of a acute inflammation stage, than to let it go and receive them later. But you can't decide when the patient comes for therapy. They may wait a while. So, but teaching the patient how to prevent it in the future and what to avoid and things to stop doing for a while until it gets better. So activity modifications and making sure they're having good body mechanics and good sitting positions and all that to avoid irritating the area. You need to unload the tendon, and typically that's really suggested for a lot of the patients. It says for anybody that's highly reactive, so if they're in a lot of pain, but this type of unloading brace is used oftentimes. This one specifically has like a little ice pack you can put there. Some of them have, or maybe even an air cushion that you can kind of blow up and release. All of them are made a little bit different, but the main thing is that they're offloading that tendon. Then initially you offload to decrease the inflammation, to decrease the pain, all that. Eventually, you begin to reload the tendon. You start to put a little extra weight on there and begin strengthening exercises. I'm so sorry, guys. It's late. I'm tired. But as the patient is progressing, you also want to teach them stretching of the area. So the best way to stretch is to extend the elbow, pronate the forearm, and flex the wrist, and then you'll kind of pull down. So you're basically stretching the wrist extensors, which are the ones that connect there at the lateral epicondyle. And so you would hold that position 15 to 30 seconds. That position is typically painful, so that's also one of the ways we check to see if that is lateral epicondylitis or lateral elbow tendinopathy. And so, again, we would instruct the patient to stop just short of pain. A sharp pain is not helping anybody. It's probably damaging the tissue. That's what sharp pains mean. And so always avoid the sharp pains, but if it's just kind of a mild or moderate discomfort, then they can hold the stretch in that position. There is a mobilization with movement technique where you do the lateral glide of the forearm. That's on page 644 of your textbook, and we can do that in lab together. Okay, so unloading versus reloading the tendon. This is just a general slide, and it will go with several of the different conditions. Unloading is taking the stress off. So some of the things that unload are the brace we talked about, taping techniques you can use to unload a tendon or an area, splinting, and then modalities can also unload an area, take the pressure off an area by decreasing inflammation. Reloading can include friction massage. So this is a friction massage to the lateral epicondyle or the lateral tendon. And mobilization with movement is another way of reloading. Stretches reload. They actually put a little more tension on an area. And then eventually progressive eccentric strengthening is good for loading. So you would start really slow and then progress. So like this guy has a weight that's on a rope, and so he is rolling. You can roll him up and roll it back down to strengthen the forearms, and you would start with very little weight to start progressively, or else you'll just aggravate the condition again. You may start with the elbows flexed and roll it up and roll it down, and then eventually once they get stronger, they're able to do it with the elbows extended. That would be a progression of that exercise, reloading the tendon. Okay, with golfer's elbow, that is the opposite. It is medial elbow tendinopathy, or medial epicondylitis, as it was formerly known, and you will hear that most often in the clinic. But the actual diagnosis from the medical doctor may say medial elbow tendinopathy, depending on when they graduated med school, or how up to date they are with certain things. So have the patient, in order to stretch this, they would do the same with elbow extension, but then they would supinate the arm and extend the wrist. So kind of the opposite for medial or for lateral elbow tendinopathy, you're down. For medial, then you turn it the opposite way. So you supinate and extend the wrist. You can also do it just in a more of a neutral without the supination, if that's more comfortable for the patient. And then you do the same types of treatments as with golfer's elbow. You're just focusing on a different area. So still same modalities, same offloading of the area, eventually reloading the area slowly. If you're doing a friction massage, it's now on the inside portion. Same with the ice massage. All the same techniques can be used, but it's just in a different area. The loose pack position. Remember, we like the loose pack position. This is kind of where there's the most joint space. So whether you're talking about the humeral ulnar or radial ulnar joint, both are at about 70 degrees of flexion, 70 degrees of elbow flexion, so just before 90. And then what changes is how much supination. So starting at a neutral thumb up position, with the humeral ulnar joint, you'll supinate about 10 degrees, and with the radial ulnar, about 35 degrees for that loose pack position. And most of the time we will do our modalities or our joint mobilizations, a lot of those types of things in the loose packed position. Now with our joint mobs. So most of our joint mobs at the elbow involve some sort of distraction. So whether you're increasing flexion or extension, both of them require you to do distraction at the elbow. A distraction of the humeral ulnar joint in a flex position will help increase flexion. And if you do it more towards extension, about 15 degrees from their fully extended position, that helps increase extension range of motion. So the only difference between the joint mobilization for flexion versus extension at the elbow is what the starting position of their arm is. It's a more of a flex position if you're trying to focus on increasing flexion and you're pulling them into a distraction force, inferior glide, or more towards an extended elbow and doing the same thing at distraction force. There's also a scooping joint mobilization we'll go over, where you take your hands and you scoop down and kind of down and in. That is particular for or specific to elbow flexion, increase in elbow flexion range of motion, but we can go over that in lab together. And then if you're wanting to do a joint mobilization to increase pronation or supination, you would do a dorsal glide, so towards the back, to increase pronation, because if you feel when you pronate, your radial head, your proximal radial head, will actually push backwards. It does kind of a posterior movement. So a dorsal glide towards the back to increase pronation, and then a ventral glide towards the front this way to increase supination. Dorsal glide to increase pronation, and a ventral glide towards the front to increase supination. Those are your joint mobs for the elbow. So as far as manual therapy, you can do soft tissue, deep tissue massage, or a myofascial release to all the surrounding areas, whatever's needed, depending on what's tight and what's restricted. And that would be based on your assessment as you're kind of feeling the area and what the patient tells you. You can also do the joint mobs we just talked about. But another is olecranon tracking. So if you're sitting posterior to the patient and looking at their elbow, you kind of find the position. If this is the clock, then it would be from 10 to 2. And you kind of push a inferior force. You hook the top and you push down like an inferior glide all the way from your 10 o'clock position to your 2 o'clock position, and you feel which area feels most restricted, which place has the least movement, and then you would kind of maintain some pressure on that area doing inferior glides. That is olecranon retracking. So you're helping a restricted area move more so that it doesn't get stuck as the patient is trying to move their elbow. So doing an inferior glide in the restricted area. Categories of exercise, there's range of motion and mobility. So mainly we just have flexion and extension at the elbow, but also forearm, pronation, and supination can go into the category of elbow movement. So getting those motions back. Stabilization, a lot of times we'll work on more kind of holding objects like a hammer or something, and you can do actually active assistive range of motion with that, or you could do strengthening with it. So you can allow the weight of the hammer to pull you into a greater motion, or you could fight against the weight of the hammer in order to strengthen. Other strengthening, we talked about the rolling. You can do towel rolls, wringing out a wet towel, rolling up like a weighted object on the end of a rope. Any of your gripping exercises are good for forearm strengthening, so you can do a lot of different gripping exercises with elbow patients. And then, of course, stretching to help maintain the length of the muscle and eventually return to function. So diagonal patterns, practicing different things that they may need to do in real life that would affect the elbow. And as you know, anytime you have an injury anywhere, you realize how much you actually use that area. So your elbow is used a lot more than you might think. The remaining slides are our case scenarios. So that is the end of our elbow lecture, and we will cover the case scenarios in lab. I'm going to pause the video so I can switch lectures, and then we will continue on with the wrist and hand lecture. All right, so we will be going over the wrist and hand therapy. So I do want to give a disclaimer. Hand therapy is very specialized. Most PTs or PTAs that do hand therapy are certified hand specialists. That is a certification that we can get. And typically, if you're working in a clinic that there is not a certified hand therapist, a PT or PTA that's doing that, if there is an OT, then you typically will refer the patients to the occupational therapist if it's a hand patient, because they kind of have more tools in their toolbox for fine motor and ADL type training that really are specific to the hand and needed for the hand. If it's a small clinic in the middle of nowhere and there's no OTs nearby that do any hand patients, there's no certified hand therapist in the area, the patient's not willing to drive, far for a specialty clinic, I just would like for you to have enough knowledge to be able to accept a patient in a condition like that. I've only had a few hand patients myself, and it's always been that exact scenario, that we're kind of in the middle of nowhere. There's nobody else willing to treat their hand. They definitely need some hand therapy, and I would rather them get something from someone who knows something than nothing, because they're not willing to drive far enough to get to a specialized clinic. But if it is something that you're interested in, I would highly recommend doing continuing education courses or even the certification course in order to get trained, because it is a highly specialized form of therapy. We will palpate these areas in lab, but some of your carpal bones are easily palpated, including the scaphoid, the lunate, capitate, and pisiform. We'll find those in class. Your metacarpals, of course, are between the wrist and the fingers. That's basically the ones in your hand. The phalanges are your fingers. And then, of course, the carpal tunnel is the area on the palm surface of your wrist that your nerves and everything travel through. So when starting a patient with hand therapy, you will first start out by observing, just kind of looking at their hand, what's going on. So there's a lot of different conditions that can occur that you can notice just by observing. So atrophy, we usually call that guttering in the hand, where the muscles have atrophied and now there's deep crevices. You can kind of see all the bones more prominent. It's pretty common in the ulnar eminence, gutter atrophy, because of maybe an ulnar nerve injury. So you could see that guttering with that. Ulna's on the outside. So that's a different type of guttering. I'll have to show you a picture of that. But this is guttering in itself. This is atrophy of the hand. The next we're going to talk about is swelling, so edema of the hand. Now, if there's edema all the way from the elbow all the way down, if it's red and shiny like this is and hypersensitive, that is a sign of complex regional pain syndrome. So if they haven't been to a medical doctor recently, maybe they were a self-referral, and that has not been ruled out, I would certainly have them refer them back to the medical doctor. If you suspected complex regional pain syndrome, that's the one we talked about, the swelling, that is a medical emergency, because if you do not do some type of procedure to release that swelling, then it can actually kill the tissue within. It can kill the muscle itself. So if it's red, shiny, hypersensitive swelling all the way to the elbow, then I would make sure that that has been ruled out before I just continue therapy. There are several deformities of the hand. So a claw hand deformity right here is when the flexor tendons draw up, such as with ulnar nerve palsy. So with ulnar nerve palsy, again, it would affect the pinky and the ring finger. Wrist drop is more likely with radial nerve palsy. It can also happen pretty often. It will happen with a patient who has a stroke or some type of significant weakness. Mallet finger is typically the rupture of the terminal ends of the tendon, the very final portions of the extensor tendons, so they're not attached in order to pull it up into a neutral alignment. So it's ruptured here, and now there's nothing attached to keep it from just sagging. If a tendon ruptures on either side of the hand, then the tendon on the other hand is the only one pulling against the movement. So if a flexor tendon ruptures, then it may be sitting in an extended position. When you relax your hand, it may be extended. If an extensor tendon ruptures, then it will kind of remain in a flexed position. The swan neck and the boutonniere deformity is a sign of rheumatoid arthritis. The late stages of rheumatoid arthritis come with these deformities, and we'll see another picture of a person's hand with that later in the PowerPoint. Hebrideans nodes are common with osteoarthritis, especially in the proximal interphalangeal joints and the distal interphalangeal joints. That's the PIP and DIP. So it's kind of a thickening of those joints, nodules developing. And then another sign of OA, of osteoarthritis, is your adducted thumb, where the thumb is becoming pulled in kind of under the undersurface of the hand. And that's with arthritis of the thumb itself, first CMC. Some of the nerve disorders. So with carpal tunnel syndrome, it typically affects the median nerve, and then they will have numbness, tingling, pain in the median nerve pattern. So it's the lateral aspect of the hand. Usually it's the thumb and the more lateral, so all of the lateral 3.5 fingers, so all the way up to halfway up the ring finger. And then the ulnar nerve can also become entrapped in the tunnel of Guyon. We talked about the handlebar palsy. So we talked about when you're riding a bike a lot with your hands on the handlebar, and the pisiform and the handlebar of the bike are kind of compressing that nerve. That can cause ulnar nerve damage there. Of course, it could be damaged up at the elbow with cubital tunnel syndrome, or it could be damaged down here in the Guyon's canal syndrome. Okay, so first we'll talk about treating hypomobility of the hand. So this could happen after someone gets a cast taken off. It could happen with either type of arthritis. It could happen with, if they have significant weakness and aren't able to move the hand for a while, and then they start to develop strength again, maybe after a stroke or some type of a, damage to a nerve. So treatments include edema control. Edema control is very important with the hand because a little edema can greatly affect the movements of the hand. So you could do some wrapping techniques. They could wear some edema control gloves, like isotoner gloves, that help keep the edema out of the hand. If you do need to do splinting, make sure it's in a functional position, because whatever position you splint in is what it's going to be stuck in. If they're stuck, hopefully they're not. But so make sure it's in a functional position. Typically they do towards extension with the hand kind of open. If anything, it might be cupped a little if they need to use that for grasping, and the thumb slightly abducted. So wrist just a little towards extension and the hand slightly open. Stretching is important for the hand. There's various stretches you can do for the fingers, thumbs, and wrist all together. If you were wanting to do a low load prolonged stretch, one of the ways you could do that with a hand without just having to sit there and hold it forever is you could actually take the hand in a certain position and then put them in paraffin. And then, as the paraffin dries, it kind of dries in that position. It's not going to necessarily hold somebody in a position, but the tape could help hold, and then the paraffin could help warm up the area. And so that's a great technique to use for someone with a hand problem. Kind of tape them into the position that you want them to stretch towards, and then use the paraffin to help assist with loosening up the area. Soft tissue massage or edema massage, again, you really need to get the swelling out of the area in order to progress their movement and their function. Joint mobilizations, we'll go over some joint mobilizations for the hand a little later, and then eventually progress strength and increase function. So I really like this picture of all the different types of, putty exercises. There's plenty more than this, but that you can do. You can roll it into a ball. You can roll it into a worm. You can, once it's into a worm, you can put it around your fingers and kind of pull it apart for more extension, or squeeze it for more flexion. You can go adduction, finger adduction, squeezing it together. You can do different types of grips and fists, working the thumb and getting involved. The putty is a great tool to use for the hand because you can shape it so many different ways and use it for strengthening, grip strength. Okay, so the joint mobs we will actually go over in lab. So these are the different areas that you can do joint mobilizations to, and we will go over those together in our lab. Rheumatoid arthritis. So we already are aware that this is a systemic disease, and late stages of rheumatoid arthritis, there are significant deformities that occur in the hand. So it's painful. There's usually swelling. There may be some warmth in the hand because of the swelling. The swelling is in the synovium. And during these late stages, the joint capsule can become weaker, the cartilage is destroyed, the bone begins to erode, the tendons can rupture because of the swelling and inflammation over time getting so great. There can be some muscle imbalances, joint instabilities, subluxations. All these basically create these significant deformities seen in late stages of rheumatoid arthritis. The main treatment is to decrease the inflammation and maintain as much motion as possible. It's a degenerative disease. It's going to progress, but if we can slow the progression down and maintain as much function as possible, that's what we would like to do. So trying to keep function and trying to keep as much mobility for as long as possible. Osteoarthritis, which of course is also known as degenerative joint disease. We know that that's from repetitive overuse or from trauma later in life. We'll develop arthritis in those areas. Typically the pain is worse with gripping and pinching when you have arthritis in the hand. Of course, it's also achy and stiff more so in the mornings or on rainy days. So it will wax and wane with that. Some of the common areas are the first CMC joint, so the base of the thumb, and then the DIP joints in the finger. It starts out typically with achiness and stiffness. Eventually, they might become hypermobile or unstable, instability there because of capsular laxity. The motion generally, even though there's instability there, will be limited. Can lead to contractures, weakness, and poor grip strength. The treatment for someone with osteoarthritis is focusing on range of motion, maintaining the range throughout the hand, some gentle stretching, gentle strengthening to maintain function. So I would do some very light therapy, some very light gripping and moving exercises, different movement exercises with the hands. With tendinopathy, remember we spoke about that as far as the shoulder goes, the tendon eventually begins to break down. I reminded you that earlier. So with the elbow portion. So same thing if it happens in the hand, it's more likely to rupture. It's painful. It's caused by chronic inflammation. So this type of tendinopathy in the hand could be from repetitive overuse, from stress, from roughening the surface of the tendon, or even from rheumatoid arthritis because there's repetitive stress on there because of the significant inflammation. Treatment, first you would unload the area. So oftentimes if it's in the fingers, they'll just do a little small brace for that specific area to offload. Educating the patient on the importance of, avoiding using the hand as much as possible, of allowing it to rest and heal and not continuously damaging that area. Tendon glides we will go over later to assure that everything's still moving properly. Stretching of the hand and the fingers, cross friction massage, to decrease any adhesions and to get some of the inflammation out, to increase the movement. Strengthening, so first, of course, you would start out with isometric exercises as you're doing kind of the offloading and taking the pressure off. And eventually you'll do more dynamic as you're going towards the return to function stage. With biomechanics, we need good stabilization of the shoulder and the elbow in order to have good movement of the hand. Remember, proximal stability before distal mobility. You guys got that by now, don't you? Okay, so for a sprain, you could sprain ligaments in your hand just like you could sprain an ankle or another part of your body. So it's excessive stretch or force that damages the ligament. It can cause pain. It can decrease your motion. But to treat it, we typically try to avoid whatever is causing that strain, that sprain. They may need a splint just to support the area while it's healing and get it kind of also in good alignment while it's healing. You want to initially unload the area, take force off the area before eventually, once it heals, reloading the area to increase strength and stability in the area. You want to maintain mobility throughout, so giving them active, assistive, or active range of motion type exercises. And then once everything heals well enough, then you want to strengthen so that it doesn't happen again. Remember, once you sprain, once you sprain a ligament, it gets more and more likely to become sprained again. Okay. All right, so with Desquervain's tenosynovitis, oftentimes you'll just hear it called Desquervain syndrome, but Desquervain's tenosynovitis, this is swelling of the tendon sheath that leads to the thumb. So the test, which is also used to stretch it slightly, is to tuck your thumb in your hand and then do ulnar deviation. And if that is painful, then that would be a positive test for Desquervain syndrome. The pain is typically right there at the base of the thumb, and with treatment, it's a lot of modalities. Again, ultrasound, laser, iontophoresis, all can be used to decrease the swelling and the irritation in the area. You can also use some cross-friction massage and some splinting to kind of hold in a neutral range in order to decrease the area. Of course, once everything, all the pain has subsided, you may do some slight strengthening, but typically mainly focus on decreasing the irritation and the inflammation to the area. With carpal tunnel syndrome, the carpal tunnel itself is a very narrow area. So if any swelling is in the hand or wrist, it takes very little swelling in order to pinch and push on the nerve as it travels through the carpal tunnel. So there's a narrowing of the carpal tunnel with carpal tunnel syndrome, and that increases pressure on the median nerve. It causes pain, numbness, and tingling in the hand. It's pain that's typically bad enough it might wake them up at night. It's in the same median nerve pattern. And for someone who's just trying to get better without surgery, a splint might be needed. We'll do some modalities, including ultrasound, just to decrease any possible swelling in the area. Manual therapy to loosen everything up, stretches, nerve glides, and I didn't put this on there, but an ergonomics assessment, because most of the time there's something that they're doing repetitively that's provoking it, like maybe sitting with not the best position at their computer while they're typing or while they're writing or whatnot. So certainly assessing the area and seeing if you need to change the ergonomics for that. If they have had surgery, you would do a lot of the same treatments, but you would also focus on edema control, really with either, but especially after a surgery. You also want to do scar mobility, because if that scar gets immobile, if it gets stuck and adhered to an area, it could really affect the wrist and hand movements. And then eventually, of course, you'll do some range of motion, make sure they're maintaining or progressing the range of motion if it's already limited. And eventually, you want to do some strengthening exercises to get everything strong enough so that it doesn't get irritated again. This is kind of a self-mobilization, like doing a scar massage to the area that they're able to do on themselves. So putting their hand on a tennis ball and rolling back and forth over that area can help desensitize the scar and mobilize the scar. So I talked about right and wrong positions with carpal tunnel. You don't want a really extended wrist, so you don't want to be sitting up too high with your arms facing down and your wrist up. You want to be at a neutral so that your arms can be straight ahead and your wrist also pretty straight, a neutral alignment in order to avoid carpal tunnel syndrome. But if you already have it, the main things will be stretching the area, doing some gripping and mobility exercises, and eventually getting more to strengthening. So this would be more like a weighted ball or a weighted object, doing some exercises with those. Okay, so with a tendon laceration, that is when there has been some trauma to cause the tendon to tear. If that has occurred and you would like full function of that area back, then you must have surgery. There's not anything we can do to make the tendon heal itself or reconnect. It won't just automatically find itself and reconnect. Ideally, you would perform that, well, we wouldn't perform it. A surgeon would perform it within 10 days. But if for some reason it goes longer than that and it's been more than 3 or 4 weeks, most likely they will not be able to perform the surgery because the proximal end of the tendon will roll down or shorten. It will retract into the hand, and the distal end will actually eventually just deteriorate where you cannot locate it. So 3 to 4 weeks at most after the injury that you can successfully repair a ruptured tendon. Ideally, you would do it within the first 10 days. So while it is healing after a surgery, then they will need an orthosis in order to block certain motions so that you do not damage it again, because if you pull on it too much, it's likely to rupture again. Eventually, once they start strengthening, one of the things you can do is a place and hold exercise. So maybe they're stuck in this position and you're trying to strengthen towards extension. You put them in extension and you cue them to hold, and you remove your hand, and of course it may start kind of slightly going towards flexion, but they're trying their best to hold it in an extended position. Usually about 5 seconds is how long we would cue for that. You could use some biofeedback to increase their awareness of muscle contractions. You just have to make sure you have a small enough biofeedback machine or pads, whatever you're using to do that, to be specific. So I've seen people cut the pads to fit that area, but you also have to be really careful how much simulation you do because it's such a tiny area. All right, so generally I talked about how important it is to get swelling out of the hand. One of the primary focuses, and probably the main focus initially from almost all hand patients, will be to decrease swelling, because even a few cc's of swelling in the hand can restrict the movement. So the main thing is getting the swelling out. If they have swelling, they will have restricted movement. And then getting function back. So it is important for a patient who has had any type of hand surgery to have therapy, whether it's from a PT or an OT. And again, a lot of times OTs have a lot of tools up their sleeve for hand therapy. They really specialize in ADL training, functional use, fine motor activities, and we really don't. That's not our forte. Most of ours is gross motor, big movements. And so unless you really have been trained for hand patients, I would suggest recommending they see the OT if you work with one. And if you don't, then I would recommend you doing more courses just to make sure you're comfortable and sufficient with your hand patients. Okay, so our tendon glides, we talked about, there's very specific positions, and if you can't remember them at all, one thing you can remember is straighten the hand all the way and then slowly flex it all the way, and that really can glide the entire tendons. But ideally, you'll memorize straight hand, hook fist, full fist, tabletop, the finger straight, and then straight fist. And that glides each individual tendon. So straight hand, hook fist, like the letter E in sign language, full fist, tabletop, where the fingers are just flat out, straight fist. And then you would go back and repeat those. Remember, when we are doing any type of well, this is similar to a nerve stretch, but it's a tendon glide, but the purpose is to glide. It's not really to stretch it. It's to allow it. It shouldn't need to be stretched. It should be long enough, but the problem is it's gotten adhered. It's gotten stuck in an area. So that's why you're wanting to glide it to kind of break away from that adhesion. So you don't have to hold these. You just kind of go through each position slowly and then go back through every position. And I would say 5 to 10 times that you would repeat each position, probably 5 since there's so many positions. But I would do it every day. And then, you could start out with your wrist in neutral and eventually progress to the flexed wrist. But most of the time I've seen it, they teach it in neutral. So that would be definitely a progression. All right, so scar mobilization. If you have a adhesion, then anything distal to that adhesion will not move. So if you're trying to pull, your hand down into a fist and there's an adhesion right here, then this portion will stay straight and everything else will bend. So that finger would stay straight like that if there's an adhesion below the distal interphalangeal joint, the DIP joint. If there's a adhesion below here, the whole finger would stay straight as everything else bent. So it's not if it's in the flexor tendon. So wherever the adhesion is, the area distal to that will not be able to mobilize as that tendon is activated, as the muscle is contracted, pulling on the tendon to move that finger. You can apply friction massage to the adhesion in order to kind of help break it up and get it moving better. If it's a flexor tendon, you apply a proximal force on the flexor side of the hand. And while you're doing that, you can also have them stretch into extension. Remember, we don't want to overstretch, so we don't push them into hypermobility, just kind of more of a neutral. Stretch them into extension. If there's a restriction, you can apply the friction massage then, and then have them actively flex the distal joint. So as you're applying that proximal pressure, and you can also do it while you're doing a friction massage, they are flexing that joint. And then after you're done with that treatment, they'll go through all of their tendon glides. All their tendon glides. So going through those back and forth. And then for the extensor, it's the same thing. It's just on the opposite side of the hand. Still a proximal force. It's on the extensor side of the hand. You'll start in a flex position. You can use your friction massage in that position and then have them actively extend while you're kind of doing a proximal pressure to help them towards that position, and afterwards do tendon glides. Either way, it's a proximal pressure. It just changes which side of the hand you're on based on if it's a flexor tendon, you're on the flexor side. If it's an extender tendon, you're on the extensor side. All right, so stretching techniques. The main stretching techniques, you can block an area and stretch what's distal to that area. So I could block just below the MCP, metacarpal phalangeal joint, and then bend there. I could block just below the PIP, proximal interphalangeal joint, and stretch there. I could block just proximal to the distal interphalangeal joint and do a little movement there. You can do stretches specific to where you need it throughout the fingers there. Just make sure you do not overstretch the fingers, because then they could become unstable. They could lead to instability. And then we have a prayer stretch. Typically the prayer stretch, the fingers are facing up, and the reverse prayer stretch, they're facing down. Both of them, you're kind of pushing the hands into each other to get that stretch throughout the forearm. And then our last part is kind of the return to function stage, but the function of the finger requires fine motor dexterity. So doing functional activities to bring back that fine motor dexterity. So you could put the patient in fluidotherapy or in a bucket of rice or even in water and have them do whatever functional movements they usually do. Pinch this, move this way, extend your fingers, screw on a lid or remove something from something. You can put objects in that bin of water or rice and have them do that, or even sand, and have them do those exact movements. You can also do Theraputty. You can do gripping, turning, pulling, twisting, finger spreading, rolling the ball, rolling snake. You can do big smashes. So all those things work different muscle groups in the hand. You can do grabbing objects of various sizes like marbles or different size coins. And you could oftentimes will work on doing one finger at a time. So grab it with this finger and put it down, and then grab it with the other, and we'll keep going. And then once they're at their pinky, they'll either start over or they'll go back the opposite direction. And then clothespin, so pinching objects, reaching task. Oftentimes I'll have them, reach over here and put it somewhere else. Theraband functional movements. So there are Theraband Grippers, as you see here, that you stick your fingers in and you can splay them or you can cup them. You can do opposition. You can do a lot of different movements within that Theraband ring. I think it's called a grip ring. But you could also just, if you just have a regular Theraband, you can make it into a small circle and open, or you can hold it right here and do, but I would just recommend a very light Theraband because your hand strength is nothing like some of the larger areas of your body. Just regular functional movements, brushing your teeth, opening a jar, buttoning and unbuttoning, zipping, unzipping, opening a can, lids, anything. Finding objects in Theraputty or in rice. With Theraputty, I really like that because you can hide all kinds of objects in it, and they have to pull it apart and spread it and do all these things that really help strengthen and build that fine motor dexterity as they're trying to search for the objects. And a lot of people really like that activity. Ball gripping, and then you can do all sorts of thumb opposition, like I mentioned earlier. So we will practice some of this, and we will go over the case scenario in lab. And if you have any questions, please let me know. That is the end of our lecture today.